If it doesn't open here and then.
Oh, okay.
There's two different spots you can click.
The quiz for the knee is due on the 6th, and it's showing up on my calendar, and I checked for settings, and I don't know why it wasn't showing up on yours. Are you in the class right there, Paul?
Trying. She came in right there.
Let's do next. The knee is due next Friday?
No,
What?
the neat questions are due today before class.
Yeah,
Yeah,
it is.
which I
The
know
quiz is
quiz
due
is
this Friday.
Friday.
That's Friday.
You said it said the 6th.
You and me,
No, I was sitting there not doing anything.
I would make sure, make sure that.
doing other.
Well, it's not on the calendar.
Is the heat thing on there for objectives today?
Yeah, but the quiz is on.
Look in February.
Today? I didn't even know.
You can submit them late.
She stays in front.
Well, I talked about what happened at the clinic. You gotta write something good or bad.
Thanks for telling me that. Where did you just have that email?
Usually not about a mile.
Then you're good for the first month, and after that you get.
See, mine don't show the quiz.
It's not showing up, and I don't know.
Did you check February, because you said February 6th.
No, you looked at it, that's went over to February, and the only thing that was the 11th, the objectives are due.
It's not there.
He's already looked at it.
Push the tibia.
I went through on your quizzes and compromised. They're now 17 minutes.
I'll take it.
Oh, the quizzes are 17 minutes now.
Okay, good.
That was 23 seconds.
Well, I found out I had to I read it, I went through all the
Still like two more.
Just so you know, I'm not crazy. I'll figure it as
Yeah,
every
that's-
class that I have.
Her pills.
Click the arrow.
No. Liquid drugs.
I just carry drugs.
Did mine show up February 6th?
I think he's doing February 6th.
I'll see it, I'll go to Michael Fox and ask him why it's showing up on my calendar and not on your calendar. But February 6th,
It's on my calendar. Well, not when you look at February, but when you look at December and you go down, it's on there.
January, you mean?
That's what I mean. January, you look down, it's on there. When you see the 6th, you see it's on there. But when you,
So starting next week, are we gonna start working on the classroom
Yes.
today?
see it's on there.
We just have to get caught up with it. We're gonna start working on the objectives and.
Now, from the knee, I've allotted 3 lecture periods for the knee in our calendar. We should now be on track. I don't know what, we should have been on track Monday, but I had to push us. So we really can't chase a lot of rabbits. I need you to do those questions, that way you have the reading pre-done. Those questions are a way of making you get into that textbook, so we can have an intelligent discussion, and I can spend the time on the, not basic information, review and that kind of stuff. But on Mondays, we'll work either individually or in a group to answer the questions. Wednesdays, we will then lecture about it. Okay? Fridays, the quiz is due.
Are the majority of our questions that we test over gonna come from our quizzes?
Some will come from your quizzes, others will not come from your quizzes. They're ones that I have got from other sources and made myself.
Oh, and your thing that you did on Monday, I tried to get it 5 hours later on YouTube, and it wouldn't,
Did it show up?
nope. So I tried every avenue I could, but that one I couldn't watch. So I watched the kinesiology one.
Today in lab, Jody is, assuming he's feeling better, will be here so we can check in on his meniscus. And today's lab will finish up the ankle like we did on Monday. So those of you who are on Monday, if you still want to come in and practice, and same thing with those of you on Wednesday, if you want to come in both days, that does not break my heart a bit. Okay, also in what I've been doing, I have gone in and put videos of all the common tests. Lockman, I don't know why there's two Lockmans on there. Anterior drawer, posterior drawer, tibial sag sign, valgus stress, and, because those are the, for you, that way you don't totally forget what this stuff is, all right? We will talk about them again when we go to the lab, but we're not gonna spend too much time on it. I'll show it to you again and let you try it. Being able to perform these tests really is not in the purview of the PTA, but you still need to know what they test and what a positive and a negative sign is. That way when you're looking at a chart working with your patient, you know what's going on. I also have been putting videos to remind you how to manual muscle test and do goniometric measurements on what we are happening to do at the time. Please, please, please take the time to go view those. I'm trying to keep them as short as possible. I really look for ones that are under a minute. Sometimes the ones that are under a minute are real junk though, so I don't want to give you junk. But those are there for you as well. I can make you view them, but if I make you view them, I can make it so the learning module is in sequential learning. You can't do the next thing until you do the previous thing, which I really don't want to do because it will then not give you this on the side. I guess you can't see what I'm pointing at on my computer. It'll just show the one thing, and then as soon as you get it done, the next thing will show up. And I know that would drive me buggy because I wouldn't know where the end in sight was. So I assume it would drive you buggy as well. That's the reason why I didn't enforce sequential learning.
It's so dumb. Don't go towards the light, Dory.
All right, so anterior drawer test is to test the ACL. Closed kinetic chain exercises, we beat those to death. Houston jerk test, Lockton exam, pivot shift, those are also ACLs. And the quadriceps angle. What can you tell me about the quadriceps angle? What's another name for the quadriceps angle? Q angle. Tends to be higher in what? Women.
And Blake.
And what?
And Blake.
And Blake.
Yeah.
Wide childbearing hips.
What is the pivot shift test? I don't remember that.
Pivot shift. The pivot shift is the gold standard exam for ACL deficiency. But to not get a false negative, the patient has to be completely relaxed. They cannot have any muscle guarding at all. Otherwise, you'll get a false negative, thinking that the ACL may be intact. I've seen Dr. Smith from River Valley perform pivot shift, and his technique is really, really good. And he can get a pretty good pivot shift exam. Usually, though, the patient is under anesthesia, and they'll perform the pivot shift while they're under anesthesia to make sure. But it's ACL, and it's high incidence of false positive. All right, so now we're going back to grading our ligament injuries because we're talking about a single ligament. Grade 1s, grade 2, and grade 3. Notice minimal, moderate, profound. Okay? So all you have to really remember is grade 1. Minimal pain, minimal swelling, no loss of joint function, no instability. And then you know grade 2s, because then you just add moderate in front of all that. Then you know grade 3s, you just add maximal in front of it. All right, function ACL. Remember, it is to prevent hyperextension of the knee in a closed kinetic chain. Actually, they'll do it in an open kinetic chain too. ACLs are typically torn in a closed kinetic chain through a hyperextension event. If you hyperextend and internally rotate the femur, with a fixed tibia, that is a nice recipe to tear ACL. That is the mechanism of injury that most female athletes sustain.
And you said that was doing what? What motion?
Hyperextension, internal rotation of the femur on a fixed tibia or in a closed kinetic chain. That ACL, the reason why the internal rotation of the tibia is because that ACL, remember, it goes up and it twists. And when you internally rotate the femur or externally rotate the tibia, what it does is it tightens that twist, and then you add in the hyperextension. It's pop. Most of the time, you remember the difference between a fusion and edema?
Fusion's inside the joint.
Fusion's inside the joint. Fusion is within the joint capsule, quote unquote swelling inside the joint capsule. Edema is outside the joint capsule, interstitial spaces of soft tissue. So one of the things we look for, especially on an acute ACL injury, is do they have any effusion about the knee? If they don't, that's kind of a glimmer of hope that they possibly didn't tear their ACL. Usually if there is effusion and the mechanism and they have effusion, that's pretty good indication they probably got that ACL. Females tear ACLs more than males, and the Lockman, the anterior drawer, and the Houston jerk test and pivot shift test all are what we use to determine if the ACL is torn or not.
Is there one that's better than the other? Cause on the
Yes.
video, I think on the Lockman, they had their knee bent up more, or no, anterior
Anterior drawer.
drawer, their knee was bent more.
Seems like that's the most common when you see the anterior drawer, like on the football fields and stuff, when you see them check.
Anterior drawer and Lockman's exam, which this is right here, is the most sensitive clinical exam you can do for the ACL. Meaning that if you get a positive Lockman's, it's like a 95% probability that you have torn the ACL. The anterior drawer, which is the next one, notice the knee bent more there, this is what you're talking about. It does, yes, test the ACL, but there are other structures that may tighten as you move the tibia anteriorly. MCL, LCL, the meniscotibial ligament. So it's not as sensitive to ACL only tear. Anterior drawer, test yes ACL, but other things that may stop the, so you could get a positive Lockman's and a negative anterior drawer and still have a torn ACL.
So would that be a thing like you might do the injury first and then be like, well, I got negative, then do the Lockman? Okay,
Yes.
I definitely.
Yes. A lot of times they're done in tandem to confirm the finding, whether you think yes, torn, no, not torn. All right, ACLs have to be replaced operatively, since they reside inside the joint capsule. They receive most of their nutrition from synovial fluid, so they have a poor blood supply. So typically they will not heal on their own, they have to be surgically repaired. And there are 3 ways. An autograft, those are the ones that are preferred. You can also do a xenograft, don't see any of those really, or a synthetic graft. It all depends on surgeon preference, whether they do an autograft, meaning they take tissue from the patient, or an allograft, they use a cadaver. Okay? They both have their pluses and minuses. Now the bone, there are several different, they can be autograft or allograft. But the 2 most common should say auto or allo graft is the using the semitendinosus ligament or a bone, patellar tendon bone autograft or allograft. Now, on that semitendinosus, let's pretend like here's the semitendinosus, here comes down the tendon of the semitendinosus towards the insertion, right? They don't remove the entire, what they do is they'll go in and strip a piece of it off. So it still remains, the semitendinosus still remains attached to its original insertion, they just borrow part of it. Kind of like peroneus brevis splitting for reconstruction of the ankle. They don't totally take it away, they just take part of it. So they can take that from the patient or they can take it from a cadaver.
Will that tendon repair itself over time and go back to its original size and stuff?
To be honest, I don't know, but I don't think so, because the tendon itself is relatively avascular. Now, the bone, patellar tendon bone, there's the patella.
You got a picture of it on your PowerPoint.
Do what, you saying?
You got a picture of the PT.
Oh, is there one in there? But what they do is they'll come in and they'll take a little chunk out of the inferior patella. They'll cut away the middle third of the patellar tendon and take a little chunk out of the tibial tuberosity, tibial tubercle. They have a bone, tendon, bone. For all intents and purposes, they are as strong as semitendinosus and the bone, patellar tendon bone they're equal as far as strength goes, for all intents and purposes. It's really surgeon preference.
Will that weaken the patella at all down the road though?
If the surgeon takes too big of a little chunk out of it, they're at a higher risk of suffering a patellar fracture later on. That's one of the downfalls to using the bone, patellar tendon bone. One of the good things about it is that you have, when they drill the tunnels to put the new ligament in, or new tendon that's gonna be a ligament, the bone fills up that hole, and some people think that you get better fixation because bone is now grown to bone. That's the good thing. The bad thing is that they're at a higher incidence or risk of patellar fracture. A lot of times you can feel that little defect in the patient's patella. You can rub your finger over it and feel it kind of go boop, boop, boop. But for all intents and purposes, they're pretty much equal. For those of you who will go and spend your career in outpatient orthopedics. Progression of the program depends on the PTA. You may as well put allograft in there too. Thank you, Wes. But you can see, take it out, bone, tendon, bone. They drill a hole through, drill a hole in, they slide it up, shove that in, put an interference screw, screw a screw in there to interfere with it backing out, to block it. We'll do the same thing down here, and some people think you get better fixation because you don't have as much, you don't have to wait for as much bone ingrowth as you do if you were using a tendon alone.
Can they do that one with the cadaver too?
Yes. If you have,
Sounds good if you could do it with the cadaver and you didn't weaken your patella too.
the downfall against a cadaver graft is it's not your stuff. Your body may say, don't want it.
Is there different rehabbing times for each one of these, or are they about the same?
They're all about the same. All right. One thing that I cannot stress to you enough, like Jerry beats things into your head, I gotta beat this into your head. They take out the grafting material, right? It's nice and strong. They put it in you, it's nice and strong. Then over the first 6 to 8 weeks, what it does is it progressively suffers avascular necrosis. Okay? So it's really strong when they put it in, and then over the next 6 to 8 weeks, it gets progressively weaker and weaker and weaker and weaker before or it will start turning around and getting stronger again.
Is that with both grafts, or is it just the elbow?
It's with both grafts. And the reason is because I don't want to say that these things are avascular. They're relatively avascular, enough so that they won't heal on their own. But they do have some vascularity. And you can think of basically, you cut you off a strip of steak. You know, you take it out and it's nice and steaky. You could cook it, you could eat it. And then you set it out on the table, and then it progressively dries out, shrinks up. Okay? That's kind of what that graft does. So, after they come out of surgery, having this done, their knee hurts. It's swollen, it's wrapped up, it has sutures, it hurts. For the first week, you taught them how to do the 4-way straight leg raises, flexion, extension, abduction, adduction, some quad sets, things like that. They're starting to ambulate again. Their knee hurts, it feels terrible. 2 weeks in, they're starting to feel a little better, but their knee kind of still sucks. So as they're feeling better, as time progresses, that graft is getting weaker, right? And at about 6 weeks, the knee feels in pretty good shape. Range of motion is coming along good. Doesn't hurt near as bad. They're feeling pretty darn good. But that's when the graft is starting to be at its very weakest. If the patient re-injures their knee, it is usually in that 6 to 8 week time frame. And trust me, they'll say, hey, I feel pretty good. When can I start running? You can start running when I tell you you can start running, not before. Can I just go shoot some free throws? Well, you'd think, sure, free throws, that's all just right there, not doing anything. Well, human nature is usually you start with a few free throws, and then it's like, hey, let's play some pig, Chris. All right, so then you start playing pig, and then next thing you know, and they haven't developed enough quad control yet to control their knee. So patient education is highly, highly important at the very beginning, and reminding them all the way through, listen, you're going to start feeling better and better and better. Doesn't mean you can do more and more and more. You only do what I tell you you can do when you can do it. So, one thing I noticed on some of these practice exams is they like to see if you know how many weeks are in a month, a lot of times. Sometimes they'll give you answer choices of when is the graft at its weakest, and they'll give you 6 to 8 weeks, 8 to 12 weeks, 12 to 14 weeks, 4 to 6 weeks. Or they'll give you 1 month, 2 month, 3 month, right? So they're asking you to recall that there are approximately 4 weeks in every month. So 2 months, 8 weeks, very fragile. Starts out good, gets bad, then goes back good again. Notice at 3 months, tensile strength of the graft is about 50% of its original strength. And as we know, during the maturation phase of healing, can take up to a year. And this is really the case with these ACLs. Now, it doesn't mean that they have to stay out of their chosen activity for a full year. Right? That doesn't mean that. It's just that most things take up to a year to fully mature. Woo! Like that. Don't you like that? I love to see that. Notice what the first thing is after goal. Protect the graft. If all else fails, that's what you're going to do. Protect the graft. Then we want to reduce pain and swelling, increase joint motion, improve strength and endurance, flexibility, and proprioception. At at this point in time, you should be saying, duh, that's what we do. It's kind of the description of my job when I work an outpatient. So, the maximal protective phase lasts 0 to 8 weeks, moderate protective phase 6 to 12, minimal protective phase 12 to 24 weeks. What's 24 divided by 4, Jay? Use your toes if you need.
I don't know. I don't wanna answer because I think I know.
It's too late, I've already called you out. You gotta answer. It's not 5,
Between 5 and
it's not 7.
Between 5 and 7.
24 divided, at about 6 months, they can start returning to their chosen activity without any restrictions. Now, some people, like David Hoyd, they choose not to have their ACLs replaced. The non-operative rehabilitation programs, look how much faster it is.
Yeah, but it's got a higher percentage of going back than the other one.
Yep.
Looks like that.
Do a reward thing.
Do what?
Risk and reward, you can get done faster, but you're taking a higher risk.
Yeah. Why is non-operative rehabilitation so much quicker than operative rehabilitation? Because it's your.
So they're not freaking going in your thing, digging it out.
What'd you say, Blake?
They're not digging out everything in their knee, causing a bunch of.
What'd you say?
You haven't had to replace it.
So, they're not digging things out and replacing. We're not waiting for anything to heal. Okay, if you don't have to wait for anything to heal, you can progress the patient as fast as they can tolerate. Questions come from those things. So, review that slide when you study for a test. Right, Jade? Daydreaming, Jade. No able to do division, Jade. Posterior cruciate ligament injuries. While ACLs are torn in a closed kinetic chain, PCLs are usually torn in an open kinetic chain. Don't tear PCLs very much because the mechanism of injury is not there very often. Function of the PCL is to prevent posterior translation of the tibia or anterior translation of the femur. Cause is usually direct trauma. And it says motor vehicle accident because you're sitting there in your car not wearing your seatbelt and you head on something, and because of Newton's first law of motion, the car stops and you're not attached to the car, so you continue to travel forward. Your shins strike the dashboard. Okay? But that leaves about that much more room for your femurs to be able to continue to go. No, it does. Then won't. We see it in athletics a lot. You see it. It's usually somebody falls on a leg like that. The tibia stops and the femur wants to keep going forward. Or translate anteriorly, or and it pops the PCL. This thing for a long time. They used to operate on PCLs. They don't much anymore. It's really, I feel like David Hoyt up here. Every time I walk in, I see him doing that. Well, that wouldn't be bad. If I could know know as much as he's
Not
forgotten,
insulted.
I would be one hell of a therapist. Yeah, it's really odd if they'll repair a PCL nowadays, usually, conservative rehab for PCLs. On evaluation, and this goes for ACL as well, we'll ask them, hey, how'd this happen? Looking for a mechanism of injury. And then we'll ask, did you hear or feel a pop or a tearing sensation? Yes. And you go, ooh, not good.
Will something like a tibial plateau fracture coincide with the PCL?
It could, if the trauma was sufficient enough. Have you seen that before? or-
No, I'm just curious about that.
On the thing says does not hear a pop or tear.
Do I?
And the thing says does not hear a pop or tear.
Oh, you still hear a pop or tear. The thing is that, that's not super important unless you're the one doing the evaluation.
Using
My-
a car wreck, you probably wouldn't hurt it anyway.
A lot of PCL injuries, are from motor vehicle accidents, are picked up by the rehabbing PT18, because everybody was concerned about saving Joe's life instead of did he tear his PCL. And we get him in rehab, and you're treating for his closed head injury, and then, got PCL tear as well. Mild to moderate knee effusion, limp pain. Sometimes PCLs will hurt back here, but so does meniscus tears occasionally will hurt back in here as well. Baker's cysts hurt back in here. So there's lots of things that will hurt in the back of the knee. Lack full extension.
So could a PCL injury kind of mimic sciatic pain, I guess?
No,
Like get that far enough to get anywhere near your nerve?
no. Plus PCL injury pain is localized, whereas sciatic
It
pain,
won't travel down your leg or anything?
I'm not saying it can't, I'm just saying that I've not experienced it or read anything about that.
The book says that you will lack full flexion of the knee.
The book says that.
Yeah, not full extension. Could it be both?
You'll probably lack both.
Is that just initially or long-term that you would lack flexion?
Initially,
Is that just because of the edema?
fusion.
Fusion?
Yeah, that's why, anytime you have a fusion at the knee, whether it be from, like, last Monday, those of you who were in, and we looked at Jody, his meniscectomy, and he had, what, right at 100 degrees of knee flexion? I can't remember, I'm just trying to remember. Anyway, the reason why he only had 100 degrees of knee flexion was not because he had a lot of scar tissue, because he'd only had the surgery on that Friday, we saw him on Monday. It was because of the effusion. And you push in it, and it feels like it's gonna go pop like a zip. So that's why controlling of pain and swelling is paramount early on. Because you get that control, you usually gain range of motion. That we do on a posterior cruciate, or the posterior drawer, same position as anterior drawer, except pulling anteriorly, we push posteriorly. And the Godfrey posterior tibial sag test, you may see it called sag sign, or the sag test, or Godfrey's tibial sag test.
Battery's going dead.
No, my wife ordered something from Amazon.
That piece of bread sure doesn't call me.
It just popped up there that Amazon sent her a confirmation email. We wonder if I got anything. Operative management, we're not gonna spend much time on operative management, other than, they use the same type of grafting materials usually as they do for ACL. But I'm telling you that it will be very odd if you see a PCL repair. When I was a student, at CI, Lieutenant Gerber, I told you about Lieutenant Gerber, haven't I? No, you're with the,
Guy that was over here.
he says, he hollers at me across the gym, "Hey, Bill, come over here." He said, "Evaluate this knee and tell me what's wrong with it." He'd already done it. So you think you guys are thrown under all the time, hey, go measure that. I was like, evaluate this knee. He says, "Just do your physical exam." So I did a physical exam. Varus valgus, Lockman's, and it was like, wow, there's a lot there. Talking about anterior drawer. I was like, oh my gosh. I thought, wait a second. Well, I get an infield there. I put him up, did that tibial sag test, that tibia went boom. So it was like that. What he had was a PCL tear that sagged so much that as you did the drawer test, the anterior drawer, you pulled and pulled and pulled and pulled and pulled before you could even engage the ACL. So it mimicked that it torn ACL, but it was actually a PCL because it had fallen so far back. I said, you tried to get me again, didn't you, Barry? Tell you what, that guy was he was so smart.
Was that an EOC?
No, that was Fort Riley, Irwin Army Hospital, where the 1st Infantry Division is stationed. All right, so there's posterior drawer, and that's what a sag sign will look like. This should be nice and straight across, but you see how it kind of dips right there? I go over these only because you might see a question from the publisher regarding it on your quiz at the end of it. But I'm here to tell you, most of the time they do not operate on PCL, so you don't have to worry about the operative. But I'm going to go over it just in case you get an odd question on that. Post-op begins day after surgery, knee immobilizer, hinge brace locked in full extension. Crutches, moderate protective phase from 6 to 12 weeks, and return to sport in 6 to 9 months.
What would be an instance where they would wanna operate on the PCL?
I don't know, if they dislocated their knee, which is pretty hard to do, so they tore ACL, PCL, tore meniscus, got the MCL as well, and they're going in there and they're having to redo everything.
Might as well at that point, I guess.
Yeah. Or maybe if they were, I don't know, not knee or something.
Then we'll talk about some high tibial osteotomy. That's what they do for those. So this right here is should be more to your liking because that's what you'll do. Non-operative rehabilitation for PCLs. Begin therapy immediately, strengthening stationary bike, elliptical pool, and then you can return to sport in 6 to 8 weeks. Okay. Again, we're not waiting for anything to heal, so we can push this a lot faster. We can push it as fast as the patient can tolerate. Medial collateral ligament injuries. While the ACL and PCL reside within the joint capsule, they're intracapsular. The MCL is extracapsular. And that should speak already volumes to you of like how quickly these things heal. Yeah, if you're outside the capsule, that means you derive your nutrition mostly from blood. If you're inside the capsule, you usually derive most of your nutrition from synovial fluid.
That's why I like you see athletes that tore their MCL and the ACL, they'll let the MCL heal before they operate on the ACL.
Right. And a lot of times, they'll go ahead and just operate on the ACL and allow the MCL to heal, because it takes 6 to 8 weeks for an MCL to fully heal up. Well, at 6 to 8 weeks, during ACL rehabilitation, you're not doing anything that's gonna stress the MCL anymore.
I just seen when they waited 30 days, and then they did the ACL repair.
Just let,
Because they're letting MCL heal, they said.
and that allows some of the effusion from the injury to go down as well. Bullet point to remember that you will see over and over again is that one right there. Most common ligament injury in the knee, MCL. Pop or tearing they'll feel for the medial aspect of their knee. This a lot of time doesn't swell near as much as an ACL does because it occurs outside the joint capsule, so we get more edema than we do effusion. And clinically, we evaluate that with the valgus stress test. Remember that. And what we're doing is we're feeling for how much the medial tibia and femur come apart. Now, a lot of times, most of the times, as a matter of fact, an isolated MCL injury, they just got the MCL, no meniscal involvement, no ACL involvement, just the MCL. They don't operate on it, they just let them heal. So what's the, when we're dealing with ligament injuries, what's the first thing that we do, always? Protect the healing ligament. Rice. So you had part of it with rice. Always protect the healing ligament before you do anything else. Okay? So, crutches and knee brace, protect the healing ligament. Maximal protective phase, we really work on quadriceps strength, and decreasing in protective phase starts at about week 2. And in an ideal world, they return to sport in 8 to 12 weeks. I say that in an ideal world. Most of the time, they're chomping at the bit, coaches are chomping at the bit to get them to come back in about 4 weeks. And it just depends on the severity. Is it a grade 1 or is it a grade 3? Grade 3s obviously are going to be closer to 12 weeks. Grade 1s are going to be closer to the 6 to 8 week region. Meniscus injuries. Let me go. Let me tell you the clinical examinations that we use. Apley's compression and distraction. Did we do that one in Kines? The grind test. Does that ring a bell? What you do is you lay him down prone. You flex the knee up. You put your hands on top of the bottom of their feet. You lean on it and you go like this.
Awesome. But they appreciate that.
And you're trying to grind that meniscus on the femur. So obviously a lot of pain would be indicative, would be a positive exam. The distraction test is just the opposite. Instead of going like this, you go like this. And you try to pull the tibia away from the meniscus. And if that decreases their pain, that's a positive. So in this case, a decrease in pain.
What was the ground test? Did it have a name for it?
Apley's.
Oh.
Apley's grind or Apley's compression. McMurray test. You have them laying supine. You flex them, their hip and knee up. Hold it here. You palpate the medial and lateral joint line of the knee. You give an internal rotation of the tibia. Apply a valgus stress. And then you let the knee extend. And what you're feeling for is a clicking or a catching. And you bring them back up. Externally rotate them. Bear stress and do the same thing. McMurray's test, but usually after the meniscus has been torn for several days to weeks. Acutely, usually the McMurray's doesn't show up. Bounce home test. Flex them up. You just let their legs straighten with gravity, but boom.
Does that hurt really bad if they have it?
Yes, they have it, yes. Also, you can kind of do it for an ACL as well, because as you do this, boom, the ACL should engage and keep you from hyperextending. Thessaly's test is the most accurate. And so Thessaly's test looks like this. I did it to myself just the other day because my knee was hurting right in the joint line. After I had done some box jumps, I thought, I probably tore stinking meniscus. So I performed Thessaly's test, which is kind of a grind exam. So they're sitting there, and what I'm doing is I'm just scouring my femur on my meniscus. Positive is when it hurts. Thank goodness mine don't hurt.
Did you hear the
That's-
grinding, or
Huh?
would you be able to hear the grinding, or just feel it?
No, it hurts. See, right now I'm scouring it or grinding it. I'm all good. Try to do this and tear my ACL. But what you're doing is your body weight, it's a closed kinetic chain exam. Now, meniscus injuries come in 3 different flavors, right? Remember these from Kines? On red, red on white, white on white. If we get a tear out here, this is what's called a bucket handle tear. Okay? The reason why they call it a bucket handle tear is you can grab that slat, pick it up, hold it, carry it like a bucket. That's why they get the bucket handle. If they're out there in that vascularized zone, they may opt for a meniscal repair.
That's more in a young person, right? Because you lose vascularity as you get older. Okay. It's like we're screwed. Bad with us, we're too late.
Sorry.
What we get is that nice shaving, reaming out of the medullary canal, a nice prosthesis, that's what we get. So, tear out here, repair. Tear in here in that red on white zone, that's a coin flip, that's up to the surgeon. The surgeon may elect to repair it, the surgeon may say, it's not gonna hold. A tear in the white zone right here, the white on white, those are surgically debrided. They go in and they cut out the offending part, throw it in the trash can, which is what Jody had done, the guy that's coming in today at 1. So, we're not waiting for any tissue to heal. The difference in rehab between a meniscal repair and a meniscectomy are night and day. Night and day.
tear patterns.
Tear patterns, horizontal, longitudinal, degenerative, flat, radial, not necessarily.
Like this post-operative rehab, that's for repair, not a meniscectomy, right?
Dirt patterns.
It was the very next slide after the picture you showed us.
That is a very, very conservative meniscectomy or a very, very aggressive meniscal repair.
We don't know that.
Cause I had the meniscectomy or whatever, I was back in work a couple days.
Yeah.
I mean, it's sore, but I was back at work.
You're on painkillers again.
I didn't take nothing, jackass.
Actually, it's not that terribly conservative, because it says back to competition in 2 to 4 months. Back to competition in about 8 weeks, and that's pretty typical. If a basketball player has a meniscectomy done, usually he's back on the court in 4 to 6 weeks, depending on the level of pain that they have. They are starting to do some meniscal transplantations. What they're doing is they're taking dead guy's meniscus, taking it out, taking what's left, ears up, putting his in, or hers. I shouldn't be sexist. I could have a female meniscus.
Well, they'll give you a female discount. Such a tear. They give you a female vagina. He's already got that.
Rehab for this is conservative, non-weight bearing, range of motion limitations, inflection, and you can start running in 4 to 6 months. The reason why we have non-weight bear is because we don't want a lot of compression on it. And range of motion limitations is because we don't want to start engaging that screw home effect. Okay? Because as you start engaging that screw home effect, you may damage the meniscal transplant. Now, articular cartilage lesion, what's another name for articular cartilage? Hyaline cartilage. This is not meniscus. No, it's 11 o'clock. So, slide number 29.
How do they attach the meniscal transplant?
I have not the foggiest. I'm guessing they probably basically stake it. I'll probably, this is just guess, I'm just, take their little rotary burr and around the outer lip of the tibial plateau to get it to start bleeding. And then put that meniscus on there, staple it in place. And then the reason why they debride that bone and get it to bleed, so they start the inflammatory response, inflammation and proliferation, so you get some scar tissue holding it in. That's wild ass gets.
That seems like that would be something really difficult to sit and write.
Like if you like
But notice that,
an old person. The other page, an older.
Well, they just do a knee replacement, I guess, is that right?
yeah. Meniscal transplants are contraindicated in people with bad osteoarthritis, simply because, hey, we're gonna put a new one in here directly.
They figure out inflammation there, it never heal too, maybe.
Is that what you figured?
You try to-
That's what I pulled out of my
ever seen anybody from